All right, so radiographs for critique, we'll run through these, and then that'll be the end of the lower leg, and we'll move on to the pelvis. So your lateral knee. What are the repeatable errors present on this radiograph? So this is given to you as one that you can use, and you can go through circle or write on or draw on, whatever's going to help you to pick out what the errors are. And the next one is the same image. So it is giving you what is wrong with it. So it's excessive rotation, and you can see that because your condyles are not superimposed. So you can see the adductor tubercle right here posterior that they're talking about. Under rotated, rotation away from the IR can be seen. So condyles are not superimposed. Patella is superimposed on the femur, and then over flexion of the knee. So your patellofemoral joint space is not open. So if you look at this, the flexion, it only needs to be 20 to 30 degrees. This is a little bit more. And then as your left knee here, you're seeing that adductor tubercle posteriorly here, and is showing under rotation, so a rotation away from the image receptor. Your medial oblique knee, what position and technical errors are present on this? So what you're wanting to see is, we talked about this joint space being completely open here. This patella to the lateral side of your femoral condyle. And here we've got no repeatable error is seen. So there really isn't a repeatable error. Slight over rotation, but not bad at all. The slight over rotation is because this patella is way out here. But you see this really nice open joint space. So even the slight over rotation didn't do any harm to the image. A slight over flexion, which is a flexion on the knee. The knee isn't kept straight, but all it did was close up these joint spaces just a little bit between the tibia and the femoral condyles. Central ray is a little too high, so your central ray is up here instead of being at that half-inch inferior to the apex. It needs some collimation, and then marker not in ideal location. So you want this marker either high or low, not in the middle. But technically there are no repeatable errors because everything is visualized. You could have just made the image better by watching the rotation, watching the flexion, and then definitely your central ray is too high. So make sure it's at that apex, a half-inch below the apex of that patella. So we're going to go on to some quiz-mes here. So make sure that you know your pathologies. So a benign neoplastic bone lesion caused by a consolidated overproduction of bone at a joint is called exostosis. A common term for osteomalacia is rickets. I went a little too quick there. So, osteomalacia, rickets. The next one, what type of CR angle is used for the AP projection of the foot? So keep in mind, you have your foot, your toes. So what central ray angle, what CR angle are you going to use? 10 degrees posterior, 5 degrees, 15 to 20 posterior, 35 posterior. And if you remember, it's going to be 10 degrees posterior. So which of the following positions would best demonstrate a Lisfranc injury? And I remember talking about a Lisfranc injury. So we need to know which position we would put the patient in and what we would be imaging for the Lisfranc. And if you go back through your notes, or if you remember, it is going to be the AP weight-bearing foot projection for the Lisfranc injury. How much CR angle for a plantar dorsal axial projection of the calcaneus? So we have a planto-dorsal axial projection of the calcaneus. Are we 20, 30, 40, or 45? And if we remember the planto-dorsal of the calcaneus, we know that we are 40 degrees for the calcaneus when we do plantar dorsal axial projection. How much is the ankle rotated medially for an AP mortise projection? So our AP mortise projection rotated medially. And with everything we talked about on the mortise is a 15 degree rotation. So we're rotating that ankle and the lower leg. So both rotated 15 degrees medially for the AP mortise projection. The CR angle is required for an AP projection of the knee if the distance from ACIS to tabletop is 21. So make sure that you know your measurements of the ACIS to the tabletop. And if it's a 0, if it's a 3 to 5 caudad or 3 to 5 cephalad, or this one we can throw out because we know it's not going to be a 15 degree. So in that 21 degree centimeter, we know that we are going to be 0 degree angle. So it's going to be perpendicular to that image receptor. Type of CR angle used for the PA axial projection, Rosenberg method. So if you need to review that Rosenberg method so you know what CR angle you're going to be using. And when you review that, you're going to know that the Rosenberg method requires a 10 degree caudad angle. All right, that's it for the lower extremity positioning. And we will come back with the pelvis.